Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
Go above and beyond.
they become very good at what they do, but only
0.1%.
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
With Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have David Leehey. He's part of nephrology. He's a professor in nephrology, a medical director. He deals with acute dialysis at Loyola University. So, David, thanks for coming.
Sure.
Yeah. Tell me about your work. Is it purely clinical? Is it research? Is it a combination?
It's a combination. I sometimes joke that, I'm a dinosaur now. I mean, I am getting to the latter part of my career. But, classically, academic medicine was clinical, teaching, and research. And then when you got older, you became an administrator. And I guess I've kind of fit that mold. So I do all four, actually. I see a lot of patients, and I do research and, of course, teaching, which is part of academic practice. And then I'm the associate chief of staff for clinical affairs now at the Hines VA. And so I'm in charge of all the trainees.
Oh, all right. What's been your experience over the many years? Have you focused a lot on dialysis or on just kidney diseases? Like, where has been your focus?
Well, for the last 30 years, it's been diabetic kidney disease.
Oh, okay. Well, diabetic kidney disease, meaning, what are some specific diseases that affect the kidney, and do they all end in dialysis? Do they not? Let's go through like a few of the major ones.
Okay. Well, the reason I went into diabetic kidney disease is because diabetes has become so prevalent in our overindulgent world, and in the Western world anyway. We eat too much, we get heavy, we get diabetic, and that's the most common cause of kidney disease. And no, absolutely, you don't necessarily end up on dialysis. You can actually do well, but one thing we've learned in the last several decades is that the patient really needs to be involved with the treatment plan. If it's just seeing the doctor once every 3 months or so, that's not going to work. I mean, the patient's got to be making lifestyle changes and taking care of themselves. So they have to watch their blood pressure, especially their blood pressure, and their blood sugar, of course, if they're diabetic. And they have to lose weight, they have to exercise, they have to practice good, healthy habits. And they can do quite well. Not all. I mean, some are just unfortunately, seemingly genetically predestined to develop kidney failure. And but still, you can slow down the rate of progression. You can still help them. But there are some people that just seem to have the wrong genes. And you can't change the parents they had, so that can be a difficult group.
Well, so how do you think that the various kidney diseases occur? Like, what are the names of the top, 1, 2, or 3 ones that people get?
Okay. Well, in the Western world, let's just talk the U.S. Okay. In the United States, diabetes is number 1. And then number 2 would be hypertension, high blood pressure. And hypertension also can complicate diabetic kidney disease. So, there is some overlap between those, but there are patients who have no diabetes and just have hypertension who develop kidney failure. So that's probably number 2. And then number 3, it would probably really depend on where you are in the country, what other factors, what kind of practice you have, whether it's a referral practice or not. But we kind of lump together a large number of diseases, which we call chronic glomerulonephritis. And these are inflammatory diseases of the kidney that can lead to kidney failure. And then somewhere along there is also polycystic kidney disease, which is a genetic disease, but that's relatively uncommon. So, I mean, diabetes just kind of swamps everything now. It's the most common.
Well, I've understood diabetes in terms of straining the beta cells of the pancreas They have to put out tons of insulin, and eventually they lose their ability to do it. But what about the kidney specifically? What are the effects that you've observed?
Okay, well, diabetes affects multiple organs, and the mechanisms are complex, but it seems the best way I know how to explain it is that early on in the course, it's the high blood sugar that causes the problem with the kidneys. And so this is the metabolic cause. But later on in the course of the disease, it's really the blood pressure more than the blood sugar that's important. And some people would argue even early on, the blood pressure may be more important. And so this is the hemodynamic cause, damage due to high blood pressure, basically. So you have damage from high blood sugar and damage from high blood pressure, and frequently, usually, of course, in combination. And in some patients, that's going to lead to kidney failure. Now, the interesting thing is we know that only about 1/3 of diabetic patients develop kidney failure. And the other 2/3 will never develop kidney disease at all, or if they have it, it'll be very mild and maybe due to something else, not diabetes. So why is that? And that's really, I guess, $1 million question. You know, when the Human Genome Project got completed, we were able to sequence the human genome. I think it was really thought that diabetes would be one of those diseases that we would find the genes for. And even if we couldn't necessarily do anything about it, we would know which genes they are that are predisposing patients to develop kidney failure. And it turns out that actually it's been quite disappointing. We have not really found clear-cut genes that are important. There are a lot of them that seem to be involved, but there isn't like a home run there. Just as an example of where we have found where the gene is important. Well, we found the genes for polycystic kidney disease. I mean, that was a known genetic disease. But we've also found the gene that predisposes to HIV nephropathy, kidney failure due to HIV.
Well, what if they go beyond gene? You mentioned high blood pressure. So in the nephrons in the kidney, you know, they're probably very delicate thin structures. High blood pressure may cause the filtration of nutrients in and out of the nephrons themselves to have a different driving force, to be stopped. I mean, maybe there's an atherosclerotic effect in the nephrons and they get clogged and shut off. I mean, how do all those factors factor in, you believe?
Well, okay. It's complex, but, the kidney is a complex organ. There essentially are 4 types of cells in the kidney. There are glomerular cells. Those are the filtering units. And they're tubular cells that eventually, make the urine. And then there are blood vessels, vascular cells, and then there are interstitial cells that are cells that are in the substance of the kidney that aren't one of those other types of cells, kind of the scaffolding cells of the kidney, if you will. And so all of these can be involved with diabetic kidney disease, but classically it's the glomerulus. It's the glomerular cells that are involved. And the glomeruli are the filtering units of the kidney. They're very interesting structures, and they have a couple features that predisposes them to damage. I mean, one thing is they filter the blood. So anything that's in the blood that shouldn't be there is going to tend to damage the kidney. And that's certainly true of diabetes, where the high sugar really takes a toll on the kidney. Now, in terms of the hemodynamic factors, that's actually somewhat complex. And I guess the best way to explain that is there's damage to the small blood vessels that lead to and from the glomerulus. And this eventually will lead to what's called ischemia, decreased blood flow and oxygenation, and the glomeruli will scar and die.
What happens to the glomeruli in the kidney under a high blood pressure situation if it's been happening for months or years? Like, what happens to damage them?
Yes. Okay. So what's going on here is there's damage to the small arterioles that lead to and from the glomerulus. Okay. The technical terms for these are afferent and efferent arterioles, but what they are is they're small arteries or arterioles that take blood to and from the glomeruli. they get diseased in diabetes. In fact, on a kidney biopsy, you can see this very easily. And we think that this is largely due to stress, shear force stress, due to hypertension.
Okay. So when these arterioles, does that mean that the glomeruli, the cells that compose them, will have compromised blood flow and then die off?
Yes.
Or is it literally the filtration and the integrity of the epithelium will be compromised?
Well, there's several types of cells in the glomeruli. There are endothelial cells, there are mesangial cells, epithelial cells, sometimes called podocytes, and they all seem to be involved. For a while, the epithelial cells or podocytes were kind of thought to be the major cell type in the glomerulus that was diseased, but it's a little bit more complex than that, I think. I think all these cells are diseased. The endothelial cells can be damaged by the shear force stress, the high blood pressure.
Okay.
And the podocyte damage, the epithelial cells are sometimes called podocytes now. And there, I think the metabolic effects are also important. I mean, one thing that's important to keep in mind is that, when you talk about medical disease pathophysiology, people tend to kind of fall into camps a little bit. And that's true of diabetes too. Some people kind of stress the hemodynamic versus the metabolic, and other people the other way. But the bottom line is that you can't get diabetic kidney disease without diabetes. So you can't get it with a normal blood sugar. They used to think you could, but nobody really believes that anymore. So if somebody has diabetic kidney disease, they have diabetes, they have abnormal blood sugar. So that blood sugar is definitely playing a role.
How do you think the blood sugar is playing a role specifically in the glomerulus? Like, has anyone been able to do a micro dissection and look at the cells in there and see if they're somehow compromised or damaged by sugar?
Well, I'll tell you, there's again, the pathogenesis is complex, but one of the factors is the glucose actually will form what are called glycated end products. So you can kind of think of it as caramel formation, caramelization, because what happens is the glucose, which is a small molecule, will become this large glycated molecule that gets incorporated into the basement membranes of the glomeruli. And one of the characteristic pathologic findings is thickening of the glomerular basement membranes. In fact, every diabetic patient with kidney disease gets that. And even those that don't have clinical diabetes, they have also thickening of these glomerular basement membranes. And this is due to accumulation of these glycated proteins. You also have alterations in the ability of the kidney to degrade basement membrane proteins. So it's a combination of increased synthesis and decreased degradation, and also accumulation of abnormal proteins, as well as accumulation of protein per se. So in other words, you've got a quantitative and a qualitative problem with this. So now there are other things that glucose can do. Glucose has effects on the production of oxidative radical species, superoxide, hydroxyl radical. And so high glucose will cause oxidative stress to the kidney. So this is involved too, especially when you start talking about the tubular and especially interstitial kidney disease. There's definitely an inflammatory component. And so drugs that inhibit inflammation may also benefit patients with kidney disease. And just recently, there's been a whole host of clinical trials that have been very fascinating, because they show that if you inhibit glucose transport into the tubular cells by what are called sodium glucose cotransport inhibitors, SGLT2 inhibitors, cotransport 2 inhibitors, so SGLT2. There are a lot of SGLT2 inhibitors that are available for clinical use now, and they've been studied in clinical trials, and they really quite surprisingly showed marked benefits in patients with diabetic kidney disease. And so how could this be? Well, they prevent sodium and glucose transport into cells. So you lose sodium and glucose in the urine. And one factor could certainly be the salt loss in the urine, which leads to a decrease in blood pressure, and that can be beneficial. But I believe, and I think a lot of people believe, that the prevention of the glucose uptake by the tubular cells is probably critical to their benefits, because these drugs have had benefits on the kidney that we just haven't seen with other classes of drugs.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
What do these drugs do? The SGLT2 inhibitors, what do they do specifically again?
Okay, so what they do is they block the sodium glucose transport. Okay, so on the proximal tubule of the kidney, there's a transporter called sodium glucose cotransporter. So this transporter allows sodium and glucose to come into the cell. And they're normally present. These transporters are there for a reason, because we filter a tremendous amount of glucose and sodium that need to be reabsorbed by the proximal tubular cells. When you use these transport inhibitors in diabetes, and even in patients without diabetes, by the way, there's some studies now showing benefits in patients without diabetes. This seems to really be protective to the kidney. I personally think a lot of this probably has to do with prevention of glucose uptake into the cell. So, back in my basic science days, we did a lot of studies, not so much in tubular cells, but in glomerular cells, showing all sorts of abnormal things that occur when you bathe cells in high glucose. It's not a good thing for cells to be exposed to high glucose.
With these inhibitors, are you essentially giving the glomerular cells insulin resistance and also salt resistance? You're making them, again, resistant to the effects of these two substances?
No, first of all, the SGLT2 work on the tubules, not on the glomeruli. So,
okay.
Indirectly, they may affect glomerular function. That has to do with a crosstalk between the tubular function and glomerular function. So they probably do tend to decrease the pressure in the glomerular capillaries. That can be a factor, but that's an indirect effect. So you can probably tell from what I'm telling you is that, this isn't a simple answer as to the
I know it never is.
Diabetic kidney disease. I mean, it's a very complex disease. And, but what we know is that if you control sugar and you control blood pressure, that really helps. The studies with SGLT2 inhibitors really seem to indicate that if you prevent glucose uptake into these tubular cells, that seems to be very beneficial as well.
In your bio, it mentioned acute dialysis. What's the difference between that and regular dialysis?
Okay, so I used to be the acute dialysis director at Loyola, our affiliate hospital. And patients who get kidney disease, and we get this question all the time from patients, am I going to get better or not? Am I going to get off dialysis? And it depends on what type of kidney disease they have. Okay, if they have chronic progressive kidney disease that's reached the point of end-stage kidney disease, the only way they're going to get off dialysis is if they get a transplant. At the other end of the spectrum are patients with acute kidney failure, and that is usually due to an acute illness. Most recently, we've been seeing this with COVID infection, and you can see it with any severe infection. That's probably the most common cause. The second most common would be ischemia, which is usually postoperative. And we still see cases that are due to contrast administration. So they're toxins such as contrast that can cause it too. But these are acute illnesses, and the kidneys may shut down to the point that patient needs dialysis for a period of time, but they should get better and the patient should get off dialysis. So chronic kidney disease and acute kidney injury are very, very different things. Now, of course, in real life, things are always complicated. So we have a lot of patients who have chronic kidney disease that then will get superimposed acute kidney injury. So that's very common.
So again, with this particular type of dialysis, it's acute, so it's based just on situation. But is the dialysis itself longer, more frequent? Does it filter things that other dialysis doesn't?
No, not really. I mean, the dialysis actually is the same treatment. The only difference can be with acute kidney injury if the patient's in the intensive care unit, which they frequently are. Sometimes we do prolonged dialysis therapies. In fact, we can even do it continuously. So we do it 24/7. until the kidneys recover. Now, as you can imagine, somebody who's on chronic dialysis would never tolerate that. Okay. Though there is a form of chronic dialysis called peritoneal dialysis. There are two forms of dialysis we do in chronic patients, hemodialysis and peritoneal dialysis. And peritoneal dialysis essentially does work 24/7 or can be set up to work that way. And the reason you can do that is, of course, the patient, is walking around, is ambulatory, isn't hooked up to a dialysis machine, carrying on his or her usual life. And so you can actually come pretty close to approximating what the kidney really would do, i.e. filter blood and remove fluid 24/7.
Yeah, I had heard peritoneal dialysis filters it from, I guess, the interstitial fluids, but traditional dialysis or hemodialysis, takes it from the blood. Has anyone come up with a combination method where there's a little bit taken from the interstitium, like peritoneal, and a little bit from the blood? Or that suck the person dry?
Well, okay, remember when you do hemodialysis, you're removing from the blood, but then there's rapid transfer from the interstitial fluid. So essentially, you're ending up with the same thing. As a matter of fact, even with peritoneal dialysis, you're actually removing from the blood too, because the peritoneal membrane has got, blood vessels. And so you're getting diffusion out of the blood as well. The difference between the two treatments is hemodialysis is a more rapid method to remove solute from the body. Peritoneal dialysis is slower, but if you're going to do it for 24 hours, 7 days a week, that's fine.
And I guess is it better to do it slower? Is it, if you try to pull off fluids too fast, can that be damaging to the person?
Yeah, some people think so. Okay, so hemodialysis is essentially flawed from a physiologic standpoint for the exact reason you say. Okay, if we bring a patient into a dialysis unit 3 times a week and dialyze them for 4 hours, which is about as long as most of them will stay, okay, at least in the United States. Okay, so we're trying to do all the work of the kidneys in 12 hours a week. Well, you can imagine that leads to issues. In fact, it's really kind of amazing it's as tolerated as well as it is. I mean, we have patients that we bring in all the time that we're removing 4 liters of fluid in 4 hours. Well, who would make 4 liters of urine in 4 hours? I mean, it's just not going to happen.
Well, you also build up waste products for, 48 hours, then all of a sudden they're taken off. Then you build them up and they're taken off. And it's a very different profile from continuously pulling them off through urine production and removal,
Sure, absolutely. And, people who believe in peritoneal dialysis, they point this out all the time. It's much more physiologic. It's much more like what normal kidneys really do.
Huh. Is there any innovation in the dialysis world, or is it like an old technology that's worked?
Good question. Unfortunately, not as much as we'd like. And I think this is one of the reasons that trainees are not so fond of nephrology right now. We're having trouble attracting trainees. I mean, that's not the only reason. A lot of these things are driven by economics. And I think trainees know that nephrology is hard work. You work hard, and the reimbursement is good, but it's not as good considering the amount of work you have to do as some other specialties. The other thing they know is that most of the dialysis units have been bought up by big proprietary dialysis companies such as Fresenius and DaVita. And so those that have an entrepreneurial side, in the past, 30 years ago, I mean, you could go out and start a dialysis unit. That's not so easy to do now. But, that's fine. It's real easy to blame the trainees and say, well, they don't want to work hard. But there's another problem that we have in nephrology, which is innovation. Nephrology, essentially what we've done is we've made dialysis much safer than it used to be, but we really haven't changed it that much. Actually, you can almost think it's pretty analogous to the airline industry. Okay, when I was a kid, I'd get on a plane. Of course, when you're a kid, you never think anything's going to happen to you. And but there was a plane crash a year in the United States back in the 1960s, 1970s. Every year we had a plane crash. Well, when was the last plane crash in the United States? I bet it's going to be hard for you to remember. The airline industry has gotten much safer. But, frankly, it's the same thing as it was when I was a kid. In fact, it's worse in a sense because of all the security issues. But essentially, you're getting on the same kind of plane and, going about the same speed. I mean, what happened to supersonic transport? Essentially, it's the same old, same old. It's just that it's much better. I mean, that's what dialysis is now. Dialysis has become a routine procedure. We don't expect patients to get sick during dialysis. We don't expect to have codes called or even rapid responses in the dialysis unit. I mean, it's really a quite safe procedure. It's like flying on an airplane, but what we really need is a new airplane. We need a new form of dialysis. Now, there have been some tweaks. A lot of people are now going home on hemodialysis, and they're dialyzing themselves 5-6 times a week at home for a couple hours a day, rather than coming in to a center. And for people who can do this, I mean, they would never want to go back to a center. I mean, they love it. And they can do it in the comfort of their own home. They don't have to drive to a center, and they can do it slower, but it's still not physiologic. There is a nocturnal dialysis, which is hemodialysis, which has become popular in some countries, such as Canada. And, essentially you sleep on dialysis. That's always seemed a little bit worrisome to me, to have your blood vessels hooked up and running blood flow at 300 or 400 milliliters a minute and be asleep.
Yeah, that's true.
And some people have actually had patients come in and sleep in the dialysis unit all night long. So people have played around with all kinds of ways, but basically it's still dialysis. And, people have tried to make it better. There's actually you probably know, there's been a big initiative in the kidney world called KidneyX. It's being sponsored by American Society of Nephrology in conjunction with industry. And I can't say that I know that much about it. I've heard about it at meetings, but what they're trying to do is they're really trying to innovate. They're trying to get bright young people to go into nephrology and make things better, to make innovations. I mean, everybody knows that patients hate coming to a dialysis unit 3 times a week and getting their blood clean and fluid removed. They hate it.
For sure.
And, it's been a very profitable business. And frankly, money talks, as you know, especially in the United States. And so there hasn't been a lot of motivation to change it, but I think it will change. But how long that's going to take, I don't know. Now, I have to say, when dialysis first came into being, I mean, it was a revolution. I mean, patients used to die of kidney disease. And 1972, the Medicare made chronic dialysis available to every American, essentially. It's still, to this day, the only chronic medical condition which is universally covered by Medicare, universally. Okay. I mean, there are rules. You have to be on it for a certain amount of time, unless you've got, a certain amount of insurance, et cetera. I let the social workers figure those things out. But essentially, everybody gets dialysis who needs it and wants it in the United States. I mean, this is amazing, really. I'm old enough to remember the committees. In fact, I actually sat in chairing a few of them, where we would discuss whether somebody was going to get chronic dialysis. Now, by the time I did it, it was a done deal. I mean, they were going to get it, but it was, they continued having these meetings. But and that was in the early 1980s. I've been a nephrologist. I went into training in 79, finished in 81. But back in the 70s, okay, and 60s, they would have these committees that would decide whether you're worthy of getting chronic kidney dialysis or whether you're going to die.
Jesus.
And yes, exactly, Jesus. In fact, they called them God committees. I mean, that was, how they were spoken of. And I don't think anybody
panels, I guess. Yeah.
I don't think anybody thought this was a good idea. And then if you go back before that, if you go back before 1950s, I mean, people just died. Where would we be without chronic dialysis, really? I mean, kidney disease has been a growth industry. It's probably flattening out now, but I mean, the last 50 years, it's just gone up, 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 up. And that's mostly being fueled by diabetes and fueled by people living long enough to require it. I mean, a lot of our patients requiring dialysis now are in their 70s, 80s, and even occasionally 90s.
Wow.
And so there's been this tremendous growth in the number of people being dialyzed. And, all these people would have died before. I mean, dialysis has been incredible what it's done, but it's time to move on. We need to prevent kidney failure, and we need to have better ways of treating it. Now, of course, we haven't talked about transplant, and that's a whole nother thing. And of course, transplantation is the treatment of choice. But we need innovations in transplant too. I mean, we've had great strides. I mean, when I was training, I could tell a patient the transplant surgeons wouldn't like it if I told them this, but I could tell them in all honesty that if you get a transplant, there's about a 50-50 chance it'll work and a 50-50 chance it'll fail. Okay. Now virtually every transplant works. I mean, so there've been huge strides in transplantation too.
Yeah.
But it's still dialysis and transplantation. It's, nothing earth-shaking. Actually, the best thing probably we've come up with that really has been a real sea change are these SGLT2 inhibitors, which seem to prevent kidney failure, not completely, but slow down and help to prevent kidney failure in not only diabetic, but probably non-diabetic kidney disease as well.
So they're in clinical use now?
Oh, yes, absolutely. Yeah. They all end with the letters FLOZIN or Flozin. So you've got canagliflozin, empagliflozin, dapagliflozin. They're a little hard to pronounce, but they're all Flozins. Yeah.
Gotcha. And then for people on them, what's observed? Is there any estimation of the delay of comorbidities or the delay of progression? How long?
Yes. Well, they can cause about a 40% reduction in virtually every outcome you want to look at, not just for the kidney, but also for the heart. Okay, so for the kidney, which is what I know better, they cause a 40% reduction in the rate of progression of kidney disease. They cause a 40% decline in the incidence of end-stage kidney disease. So they're really amazing drugs, and they're going to be used more and more. Now, are they completely safe? They're quite safe. There are some serious side effects. Fortunately, they're rare, but patients can get life-threatening diabetic ketoacidosis. They can get life-threatening and even fatal Fournier's gangrene of the scrotum. That's probably directly related to all the sugar in the urine, because these drugs prevent sugar uptake by the kidney cells. So you end up with a lot of sugar in the urine. And it used to be thought that urinary tract infection was also more common, but that doesn't seem to be true. I think you have to select the patients pretty carefully. Even though I understand diabetologists are actually giving these drugs to type 1 diabetic patients now, they're not approved for that. I think there's a risk of ketoacidosis when you do that. And even in type 2 diabetes, you can get ketoacidosis, but it's treatable. The Fournier's gangrene could be bad luck or just not a good patient selection. I mean, patients have to be clean if they're going to take SGLT2, and they can't be incontinent. I mean, they can't be wetting themselves. I mean, they can't be in diapers. I mean, they have to be bathing every day, and they can't smell like urine because then they're going to get into trouble. Other than those things, my experience with them has been they've been quite safe.
Well, very good. We've covered a lot of ground, and we're out of time. What's the best way for people to follow up and to learn more about your activities? Where can they go?
Well, probably the internet. Is probably, like everything else, probably the best way. If they want to go further than that, I suppose they could contact me.
Yeah, I didn't know if there's any particular papers or, the general website, Loyola, people can look at. What's your recommendation?
Well, sure. I mean, okay, one thing, depending on what people are interested in. I mean, I have written some textbooks. So, they could look. I've written 2 editions of the Handbook of Nephrology. And I also wrote a little book called Nephrology Rounds, but that one I think is more for people in the field. But Handbook of Nephrology, I think, is great for any trainees, not just medical, but I think nursing and other associated health trainees would be interested in it, medical students as well. So, those books are available. My papers, of course, if you go into PubMed or Google or whatever, you'll find any paper that I've written if they're interested in looking at that. What else could I tell you?
Yeah, I think that's good. So, I just want to thank you for coming on the podcast, and you have a lot of knowledge to share. So thank you for being here.
Well, thanks. I know we kind of touched on a number of different areas, and that's fine. It kind of gives you a little bit of an idea of what I've done in my career, because I have done basic and clinical science. I didn't mention, just in 30 seconds, I'm doing a big clinical trial now with a drug called pentoxifylline. It's PENTOXIFYLLINE. Okay, that's too much for any of us. So we call it PTX. This is a drug, the brand name in the past was Trental, Trental, and it was used as a drug for peripheral vascular disease for claudication. Really not used for that anymore, but it's an approved drug. It's been around since the 1980s. And so, to make a long story short, there were a lot of small studies that showed it could be beneficial in diabetic kidney disease. So we're doing a big clinical trial in the VA. We're going to have 40 VA sites ultimately, and about 2,500 patients. So we're going to see whether this helps.
Well, very good. Well, again, David, thank you for coming on the podcast. I appreciate it.
Sure. Thank you.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.